One of the first dysrhythmias that we're going to talk about is sinus bradycardia. Sinus bradycardia still originates from the SA node because it has the prefix sinus. When you're considering anything that you're classifying as sinus rhythm or sinus bradycardia, it has to indicate that the impulse generated originated from the SA node and it follows the normal conduction pathway. Otherwise, it would not have the term sinus. With sinus bradycardia, the SA node discharges impulses at fewer than 60 beats per minute. So when you're considering this, you see a sinus rhythm with all sinus elements, but it's less than 60 beats per minute, you would classify that as sinus bradycardia. This can be normal in a lot of people. Young people, really active people, athletes, for example, because of the conditioning of their heart, they have a slower heart rate normally because they are more efficient. So, and also during sleep, your heart rate can decrease because of the metabolic demand decreasing. Sinus bradycardia can be an occurrence when you are vomiting. You are stimulating the vagus nerve, which then in turn would slow your heartbeat down. So vomiting, bearing down, coughing really hard, holding your breath, those kinds of things can slow your heart rate down, but it can be transient and it will be self-limiting once that stimulus goes away and you stop stimulating the vagus nerve. Now you would see that the heart rate would restore back to a regular, normal rate. It is the most common dysrhythmia associated with an acute myocardial infarction, which is the representation of AMI, and often seen with an inferior or posterior wall myocardial infarction. So you will see bradycardia with people who are having cardiac ischemia. Let's take a look at a couple of strips with sinus bradycardia so that you can see how we're using our triple R method to evaluate our strips. And we want to keep using that consistent method going all the way through so that you can have a way that you will look at a strip the same way every time. It will be very beneficial in identifying problems. So just looking at this strip right here, I can see that the heart rate is slow. If this were a 6-second strip, I see 4 complexes on the strip. So already I know that's less than 60, which is going to classify it as bradycardic. How do I get the S in there for sinus bradycardia? Well, I can see that there are P waves across the strip. So first of all, rate. I look at my rate. My rate is about 40 using the 6-second strip method. Let me test my regularity and see my rhythm, which is R number 2. If I put my lines again, I can see that these QRS complexes are evenly spaced. My third R is relationships. I'm going to look at my relationships and I can see a P followed by a QRS on every complex, and the morphology of the complexes look identical. So morphology is going to come into play later on when we consider other dysrhythmias or funny little beats that might come into our rhythm strip. And we might have to do further analysis of maybe 1 beat or 2 beats on our 6-second strip. But for all intents and purposes, this top strip is sinus bradycardia at a rate of about 40. It's sinus because it originates from the SA node. How do I know that? Well, I see a P wave, an upright, rounded P wave. That signals atrial depolarization, and it signals that the stimulus came from the SA node. I can call it sinus because I see a QRS following every P wave, and they go together with good relationships. So sinus bradycardia. On our next strip, let's count this one out. The complexes are a little bit smaller, so they're harder to see, but they're still in existence. There are QRSs. I see 1, 2, 3, 4, 5. So that's a rate of about 50. I can also see that they're evenly spaced. So I have a rate of less than 60. I have a rhythm that's regular. And I do see a P wave with every QRS, so my relationships are intact. So that indeed would be classified as sinus bradycardia. Let's look at some of the causes. You can see a big litany here, a long list of things that could cause bradycardia. Any number of things. You could have it with your myocardial infarction, right? Or your cardiac ischemia, right? Myocardial ischemia. Some kind of disease on the SA node. So maybe they're moving into sick sinus syndrome, so their sinus rhythm starts just slowing down. Increased vagal tone, so very sensitive to the vagus nerve stimulus, which would then slow the heart rate. But you can see here hypoxia, hypothermia, hypothyroidism. Those hypothermia and hypothyroidism in particular really work on the metabolic rate. They slow it down, right? So therefore you would have a slower heartbeat. But any kind of electrolyte abnormalities like hyperkalemia, which is a high potassium, it could happen with drug toxicity, in particular beta blockers, calcium channel blockers, or digoxin. Those types of drugs will slow the heart rate down. A beta blocker is blocking all of the beta cells located in the heart. Therefore, they will be less responsive to the stimulus and the heart rate would be slower. Here are some signs and symptoms. So when you see the green writing on some of the slides, that's kind of for ACLS. So if you don't have any signs and symptoms, meaning your patient is stable, they don't have low blood pressure, they're not having altered level of consciousness, they're not having diaphoresis or skin signs, then you would simply monitor them. If they start showing symptoms of decreased cardiac output, which you can see listed here in green, then you would want to say, I might need to do some actions. The minute somebody has chest pain, regardless of their vital signs, they are now symptomatic and you need to do something about it. But you can see signs of decreased cardiac output such as shortness of breath, hypotension, changes in their mental status, right? Decreased level of consciousness, skin signs, I'm cool, I'm clammy, I'm pale, perhaps I have a decrease in urine output. Those are all signs of lowered cardiac output and therefore making the patient symptomatic. Interventions for sinus bradycardia on a patient who is symptomatic, you would definitely put some oxygen on them, get an IV, maybe check their vital signs, check their blood pressure, get a pulse oximetry going, and the drug of choice would be atropine, 0.5 milligrams every 3 to 5 minutes, up to a maximum of 3 milligrams. We may need to pace this patient. You might need to prepare them for transcutaneous pacing. You wouldn't want to delay this if you see some signs of block. So pacemakers and blocks are covered individually toward the end of the class. And that will kind of solidify your understanding for ACLS management of this patient. You can also consider some drip medications like epinephrine and dopamine to stimulate the heart to beat faster. Definitely you want to be treating the causes if you at all know them. I hope you find this presentation on sinus bradycardia helpful in your understanding of causes and management, and also how do we recognize our rhythms. And you want to start really implementing that triple R method, right? Rate, rhythm, and relationships all the way throughout the course, so you have a set mechanism to identify when things are outside of the normal rhythm. As always, you can put any questions on the Raise Your Hand discussion board, and I'll see you later on.